So I'm also going to talk about lens sizing using ultrasound, but I'm going to talk about the use of high frequency ultrasound. And I'm going to try and put it into the context of all the work that Dr. Kojima and others have done before us. My financial disclosure is that, yes, of course, I developed an ultrasound scanner, as many of you know, and this was me in 1996 on the floor there at Cornell University, and that's Ron Silverman. And so we have a financial interest in this device. I can't say it's much of a financial interest, but it's been certainly a work of passion for us. Both these devices are approved all over the world, they involve a remodeling of what is the standoff medium, so that the patient can be scanned while sitting. The big innovation is in the ICL, and making it comfortable, making it very quick to fill the chamber, which is a sterile chamber. This is a sterile disposable, a sterile chamber that is separate from the scan chamber, and which only takes a few seconds to fill with BSS. So the examination I'm going to show you here takes about 2 minutes in total per eye. Takes a few minutes just to explain to the patient what's going to happen. Obviously, that they're going to open their eye in this warm saline, but once the head positioning is done, then sorry, but that didn't work. I've got some animations here. I've sped it up, but essentially, I'm going to try and time my speech to the video here. Once the position is set, then we fill the chamber. As you'll see here, the water coming in, the patient opens their eye, we range it, we take the scans, we unfill, and the patient comes out. That whole process basically takes 2 minutes per eye, and it's very, very easy to do. And as we've repeated, and all of us have repeated many times so far this course, the risks of ICL surgery and the complications are by and large to do with the sizing of the lens itself. And so it's useful to look, as John took us through the history of the model of the lens, I'd like to take us through the history of sizing. Because in the late 90s, when Carlo Visolo was one of the first people to be aggressively using this technology here in Europe, and wrote a textbook, 300-page textbook published in 1999 on the ICL, sizing was still a very primitive equation, and it was essentially white to white plus 0.5 millimeters. And that, let's call that version 1. And there are historical publications. These are before the ACK report and before anything but white to white sizing, that showed that if the lens was within 90 microns of the crystalline, if the ICL was in 90 microns of the crystalline lens, there was a very high chance of developing anterior subcapsular cataract. Now, the OCOS website, the STAR sizing formulation, actually now includes a multivariate elements, as far as I understand. In other words, the refraction, which of course relates to what lens power is being used, is included. The keratometry seems to be a factor that predicts volt, and the ACD predicts volt. So these are essentially, as far as I can make out, the parameters which STAR is using in their OCOS website. It's all about this correlation, right? This white to white versus, the posterior chamber dimensions, which is where the lens is actually going to go. And so because of the correlation coefficient being low, and here's one of the earliest studies published on this with Mark Rondeau at Cornell. We used a rectilinear scanner to very, very accurately measure, and he basically did a whole analysis of the ovality of the sulcus. And you should read this paper, because everyone thinks that the vertical is always wider, but it isn't. And he did some very clever fan plots to show the probability that the vertical will be wider than the horizontal, et cetera. So it's a very, very big treatise on the anatomy of the sulcus here and correlating it to the white to white. We published a paper clinically here with the Artemis 1 in London, and you can see that the coefficient is 0.32. It's just a very low correlation. So yes, there is a correlation, but there are a lot of outliers from the expected correlation line. And all of the UBM studies, which are of course lower resolution, lower repeatability, still came to this conclusion, and it led to sulcus-to-sulcus sizing. Lovisolo had been doing this in the late 90s already. Doherty, of course, published the paper from his FDA data, which the US has been using diligently. His lookup table, of course, includes the ICL power, which tells you about the mechanics of the lens, the bendability of the lens. The higher power ones are thinner in the center, so they bend more. But then, Kojima came to us with, a brilliant, everything that's obvious is obviously brilliant because no one else thought about it. But obviously, the reason why the Kojima formula is better than the Doherty is that the lens rise subtracts volt from the same sulcus position. And so Takashi very cleverly introduced this and did some beautiful multivariate regression analysis for us and provided us with his formula, which I called version 2.5. I want to just go back to the paper which was quoted earlier, Mark Packar's review paper, which went out in Clinical Ophthalmology. Now, essentially the value of that paper is obviously in the outcomes and the visual outcomes and the long-term safety and the stability of the refraction and all that. But the section of this paper on sizing is really flawed. And I'm not a statistician myself, so I sent this to a statistician, and that's Mark Rondeau, whose paper you saw, I quoted earlier. And Mark had a look through this, and he basically critiqued it. So basically, if Mark had reviewed this paper, it would not have been published. Essentially, he said that all of these studies that were included regardless of how the study was designed. There was no protocol applied to assess which studies were going to be included. And essentially, none of these studies would be acceptable in an actual, like a formal systematic review, right? Remember that systematic review is not a casual term, it's a scientific term. There's a protocol for doing systematic reviews, and none of that was applied in selecting the studies. Only 3 studies using sulcus-to-sulcus sizing were included, and there were 24 studies with white-to-white. Now, that might just be because those are the only studies he found. But here's the thing. What he did was he pooled the standard deviation analysis, and that is just statistically incorrect. You cannot do that. If you do that, this is what happens. He came up with the conclusion that the 95% confidence interval for white-to-white sizing was this little red line here. And that's pretty amazing considering, the reviewers can't have even read the paper because they're claiming that standard deviation, that 95% confidence interval came out of all of these individual 95% confidence intervals. It literally makes no sense whatsoever. So it was wrong. So what did he do on top of this? So he said, well, all right, let me try and do this, and he said the data is very dirty and it's not really possible to do this kind of study like this. But what he did was he took the statistics, the means and standard deviations, and synthesized the populations using random number generators in a normal distribution. Now, this is assuming a normal distribution. And then he used that to calculate the overall variance for each method. And, when you did that, it showed that sulcus-to-sulcus sizing had a lower variance than white-to-white, which is actually the result that you would expect, not that it's the same. For obvious reasons. I mean, if you've got size 8 gloves, you probably have size 9 feet, but not necessarily, right? It's better if you just measure the foot directly. Lovisolo was very, very interested in this, and he spent a huge amount of time looking at the repeatability of all the different UBM devices. Remember, I'm calling UBM a handheld device where you have to lie the patient down, put an eye cup in, standoff medium, and handheld find the plane of the sulcus, which is has the greatest meridional length. Now, we looked at repeatability as well, but we looked at it with the Artemis 1, which was the prototype, and now the Insight 100 from ArcScan. And this is Carlos' data, and you can see why essentially people trying to use UBM for sizing were getting, results that weren't necessarily any different from their white to white sizing. So that's a conclusion which may be correct for that individual setting, but it depends on the user. And Takashi just showed us the inter-observer repeatability of UBM is extremely high. And of course, the Insight 100 is a robotic scanner with autocentration, so there is no inter-observer repeatability. There might be intercession repeatability, but the resolution of these scans is, of course, much, much higher, and therefore it exquisitely delineates the zonules and all of the features of the posterior chamber in a way that we just can't do with 30 megahertz scanners. Remember, these scanners, the nomenclature of ultrasound transducers is very confusing because it's not done correctly. In the nomenclature, if these are called 50 megahertz transducers, this would be called a 70 megahertz transducer. That's talking about the highest frequency of the 15 dB bandwidth. What really you should be talking about is the center frequency of each of these spectra of transducers. Anyway, just to say that we were now using this commercially available, highly roboticized, perfect scanner, and we were going to use Kojima's equation because it's technically the most sophisticated equation out there, and we've expected to get better results than Takashi himself because he was using a handheld ultrasound and we were using a high-tech robotic scanner. Of course, in comes OCT around the same time, and people talk about it as some kind of either or. I don't see that at all. I see them as, in fact, very complementary technologies. In fact, I see it as a beautiful love affair. And as you will see in my talk after the break, I believe that if you really want to do ICL surgery at the very highest standard, you're going to want to have both devices and both technologies in your practice. You see, measuring the white to white is one thing, measuring angular dimensions inside is another thing, but if you don't have sulcus information, which you cannot get from OCT unless certain parameters are met, and I know that there are more infrared OCTs out there, but there's a lot of confusion as to whether it's possible to scan through the pigment epithelium and actually see the zonular plane. And the zonular plane is actually what determines where these haptics are going to sit, where these foot plates are going to sit. Not only that, but let's be clear. When we look at the outliers, we know now that the sulcus and the angle can be the same size in some eyes. The sulcus can be larger than the angle in some eyes. The angle can be larger than the sulcus in most eyes, but there can be different sulcus anatomy, and not just within patients, but between the eyes of the same patient. Here's a patient with sulcus, some kind of sulcus recession anatomy on one side, but not the other. And so the very anatomy of the sulcus is important to understand. And finally, iris cysts. Iris cysts are very, very common. In fact, they're way more common than you think. Now that we scan, of course, everyone pre-op, we're finding these everywhere. And we didn't manage to get this into the literature before our colleagues in China did, but essentially, they're showing that 27% of patients have ciliary body cysts somewhere in the eye, and 12%, 6%, that's 1 in 15 of the patients have them in both eyes and multiple locations. So how did we approach this? Well, we took the whiteboard approach, and we took all of the measurements we could conceive that might be of use: the antechamber depth, the angle of the angle, the angle to angle distance, the sulcus to sulcus distance, the sulcus to sulcus lens rise, the zonule to zonule distance, the zonule to zonule lens rise, and the ciliary body inner diameter, as I called it. I mean, in fact, that was the last one we put in. I said, I don't think it's going to be of any interest because ciliary processes, they kind of float around. So when you scan, you might be scanning in the plane of a ciliary process or not. And I thought that probably isn't a valuable number, but let's just stick it in. Of course, we always have the non-anatomical parameters there. They've always been there, the white to white, the ICL power of the lens we're implanting, and the scotopic pupil, which had already been shown to change the volt postoperatively. You know, the lights are on, the volt goes down. What we found was, again, a regression analysis, multivariate stepwise regression analysis, and our significant factors were ciliary body inner diameter, sulcus-to-sulcus-lens-rise, scotopic pupil. And what was fascinating was that no matter what we did, we could not get the sulcus-to-sulcus to be in the equation at the same time as the ciliary body inner diameter. We used nonlinear regression analysis and we tried to get it in somehow, but we couldn't. And so what this told us was that the ciliary body inner diameter is such a strong predictor of the volt of the lens that you don't need the sulcus-to-sulcus anymore. And it turns out the sulcus-to-sulcus itself was only a correlate to what this volt was going to be. So our formula, if you don't mind us, boldly calling it version 3.0, includes 3 terms that were never described before. And rather than recommending a lens size, what we did was we said, no, forget about that. Let's use these parameters and let's give what the volt would be for each of the 4 available sizes. Because as Takashi pointed out to us, you might want to select a higher or a lower volt depending on the eye. We programmed everyone's equations. This is the Nakamura 2 and Doherty, the Kojima, and our own equation here. And all you have to do, whatever, it's like the ASCRS website. It's free of charge to use. There it is. If you enter all of the parameters, then you'll get all of the equations and you can compare the results. But if you enter only the parameters, relating to ours, then you'll only get our. So depending on what you enter is what you get out of it. So the way we used and produced this was as follows. Like I said, we used a training set, if you like, which was using the Kojima formula. And using those 42 eyes implanted by Kojima directive, we then did a multivariate regression analysis and came up with a formula version 1 that was on 30. And then we applied that formula to 36 eyes prospectively. And then we did more eyes. And by the time we got to the end of those eyes, we pooled all of the eyes together and did another calibration, if you like, of the coefficients. And so here is the training set. Here's the interquartile range with the training set using the Kojima formula and the Insight 100. Here was Formula 1 and the interquartile range, and here's Formula 2. Now, for the sake of ease, in the paper which we've just submitted, we just combined Formula 1 and Formula 2 to give us the bigger numbers, even though it makes the results slightly less good than Formula 2 alone. But here's the pooled results of our formula using the Insight 100. And what we then did was to back calculate, based on our model, what the volt would have been if we had used the lens suggested by any of the other formulas. Obviously, if it's the same lens as the one that we suggested, then that would have been the volt. And if it was a larger lens, it would have gone up by whatever our equation would have predicted that volt to be different. So this is a model, okay? But it does show you that by and large, the STAR, which I think everybody knows this by intuition, the STAR formula tends to be a little bit high, and a lot of people subtract one size, usually often from what they see on the OCOS website. But the Iragashi, the NK2, just a little bit higher, than the ultrasound Kojima formula that we got. And so this is just an overall picture, okay? But let's look at the interquartile ranges, because that's kind of like a measure of dispersion, right? And you can see that the dispersion that we have, even combining Formula 1 and Formula 2, is exceedingly low, and it's way lower than anything we had before. And it's really the outliers that we're interested in getting rid of, because the exchange rate of the ICL is very low. Even with white-to-white sizing, it's very low. So what we're trying to do is to get rid of the outliers so that we can get rid of the exchanges. That's the key here. So tightening the interquartile range, tightening the full range is what we're looking for. So we just looked at this, in another way. We said, well, based on the size that we chose, what were the other formulas choosing? And I'll just single out the OCOS, which is obviously the oldest equation. 17% of the time, the OCOS website recommended a size that was 2 sizes larger than the London Vision Clinic formula did. And where does that apply? Well, let's show you an example. This is our Excel spreadsheet. We're not using our own website, but we have the formulas obviously in-house. And so for this case, we chose to use a 12.6 and target a volt of 568 and 547. Now, the STAR formula suggested a 13.7, but we put in a 12.6. That's 2 sizes under. Now, instead of getting 568, we got about 800 and something. We got about 250 microns more in each eye than predicted. Okay, that's fine, because we put in a 12.6. If we had put in the 13.7 and it had been 250 above 1,000, that might have put us into lens exchange territory, depending on the AC depth and the angle and all of that. So the point here, as I'm saying again, is about eliminating the exchanges. It's, the volt is exceedingly forgiving, I think is the best word we can use. So if we look at the regression, and not many have plotted these graphs. I know that Takashi can do that now, but we were the very first to do this. Everyone always talks about the volt being within reason, like between 250 and 1,000, but we're actually looking like refractive surgeons at attented versus achieved. And you can see that we had a little bit of a tilt in our Formula 1, but actually with the more eyes, this now became a rather one-to-one correlation. And here's the analysis of within 100, within 200, and within 300. And Takashi, thank you so much for adding that analysis to your talk when we corresponded before the course. And I want to just point this out. So with direct measurements in the posterior chamber, from high frequency ultrasound robotic scanning, we're getting 61% of the eyes within 100 microns of intended volt. And remember, 1 hair is 100 microns. So 86% within 200, and almost all of the eyes within 300 microns of the intended volt. Now, compared to the others, clearly this is, an order of magnitude kind of is, if you like, better. Let's look at the within 100, and obviously OCT is better, and the Nakamura, the NK2, and the NK3. Now I'm very excited about that. Better than the original STAR formulations. STAR really, if you're using the OCOS website only, you're now really behind, because obviously OCT is better. But high frequency ultrasound direct measurements of where the lens is going to be placed is even better. And obviously it's better. It's not being rude. It's just that if you're trying to predict posterior chamber dimensions from anterior chamber dimensions, and what you're trying to do is eliminate outliers, then models will not eliminate outliers, right? Because models are about the average response. So the average response gives you a good sizing, whereas it's the outliers, and the outliers are therefore the ones that must be imaged directly in the posterior chamber. And that is probably why we get so much better sizing. Now, here's Takashi's slide just now, and I've not put these numbers in, but Takashi, that was great. But you see, we're still quite far apart with a 100 micron predictability. And that's understandable, right? We're measuring directly in the posterior chamber rather than into the anterior chamber. It goes without saying that the outcomes of and this, the safety and the efficacy of this technology is absolutely, gobsmacking. The accuracy in the high myopic range, maybe vertex distance allowing for some errors, but it is just remarkable how accurate this technology is. It's as accurate as your refraction technique is. And so it's not about the lens itself, and we now have lots of holes in the lens, and it's a beautiful loading technique with Shiraz's special forceps, and we have the refinements of the implantation technique. We really need to finish this thing off now, and I really believe that the efforts being made by Dr. Nakamura and Dr. Kojima, our efforts, Alonso, those, Saldivar, all of us around the world who are really fretting about sizing, I think in the very near future, I think we're already getting very close to perfection. Perhaps we're on the doorstep of perfection. Certainly our formula now, and I've heard others who are Insight users. I think I've seen a few of you online here. Maybe you can chime in later on the discussion as to your experience using the formula without us looking over your shoulders. But it's almost like you can choose the volt of the lens now by using high frequency ultrasound. So thank you very much for that, for your attention on that.